This week on the BackTable Podcast.
Most importantly, the time moves really quickly. It doesn't feel like things are moving quickly when you're in the heat of them and you just kind of are trying to get to tomorrow. The opportunities that you may have during those time periods, you may not have as many opportunities as a junior. It's important to actually take advantage of things because you'll blink and PGY3 you'll be over and you'll be happy that you're there, but reflecting on how quickly everything went. And it's important to make all of that time worthwhile.
Hello, everyone, and welcome to the BackTable Podcast, your source for all things urology. You can find all previous episodes of our podcast on Apple Podcasts, Spotify, and at backtable.com. Welcome, everybody. We're very excited to be here. I'm Lindsay Hampson, and I'm here along with Gina Bottolato. I'm going to let Gina say hi.
Hi, everyone. Great to be here.
We're super excited to be rekindling our podcast show, talking about education with residents and trainees. And today we have a really special guest that we're very excited to have, Nathanaelle Ibeziako. She's a third-year resident at UT Southwestern and really a Dynamo resident who Gina and I have had the pleasure of talking to before. So we're super excited to have her join us and talk about the challenges of being a resident and how to kind of overcome these challenges and how to set yourself up for success in residency. So Nathanaelle, welcome.
Thank you guys so much. I'm so excited to be here.
Welcome. Yeah, I think we were so excited when we first met you as part of the AUA kind of academy/fundamental series where you served on as an expert panelist about some of the pearls of wisdom that you garnered as you completed residency. And we really wanted to have you talk a little bit about the perspective as someone who's just completed their junior years of residency. So from their internship to their PGY3 year. So first, why don't you tell us a little bit more about you, tell the audience a little bit more about you, where you're from, how you got interested in urology, and then we can talk a little bit more about your early career days in residency.
Yeah, so I am originally from Cleveland, Ohio. I decided to leave Cleveland and look for a larger city and decided to go to Tufts and Boston for medical school. It was there that I initially was kind of, still in the pelvis, but started off being interested in OB-GYN. Quickly, that changed when I felt like I didn't get the diversity in cases and patient presentations that I wanted, and I kind of navigated through all the different fields of medicine and decided I was still interested in something surgical or procedural, but didn't feel like general surgery necessarily satisfied it for me. I had actually a church member of one of my family members who was a urologist who asked me to come shadow her at the end of my second year of medical school. And then I went on to kind of build an elective based off of spending a day with her. And I went and did a month in a urology clinic and working directly with her. And the variety for me was what kind of held me. And then going through third year of medical school and not feeling the same way I felt with seeing the variety of cases, the variety of patients, going from office-based procedures to really extensive intra-abdominal open procedures. I did not get that experience in any other field. And I was like, well, I found my home and we're here today.
I want to ask you a little bit more about that. I know it's not the kind of main focus for today, but I think there's a lot of students who listen to our podcast and, the experience you share of feeling like you have to go through kind of a lot of different rotations before you find urology is probably a really similar one that a lot of people have. I think some people get exposure because they're lucky enough to have rotations as part of their program, their school, but a lot of people end up having to kind of find mentors like you did outside of their regular rotation schedule. And maybe just talk a little bit about how do you go seek out those people? Because that's part of your early learning curve too, right? Is finding people who can kind of mentor and guide you in the process.
I think, that was something that I saw with myself and also with a lot of peers at other programs that maybe didn't have as much urology representation. We kind of had to go out of our way to find experiences. And sometimes it's not just specific to urology. It's like all of the surgical specialties. As I was making my rounds through everything, I had to find ophtho and ENT experiences just to see whether or not I liked the field, but I had to kind of seek those things out myself. And so I think exposure to urology, it's actually built into medical school education. That's more than maybe like 2 weeks of didactics, would definitely bring a lot more people into the field.
Awesome. And I think kind of dovetailing on what Lindsay was talking about, that transition from being a medical student to residency, I want you to kind of hone in on those early days. So tell us a little bit about what were the challenges in the learning curve and completing your sub-internship and then showing up for day one of being an intern, a resident. This is a transition that many residents are making tomorrow or in a couple of weeks as the new academic year rolls around. So tell us about what the major challenges were in that adjustment and how you overcame them.
I think the two major things for me were assuming the amount of responsibility that you have to assume as a resident compared to a sub-I. Especially on a surgical rotation. Surgical rotations, you have a little less independence as a medical student than you do maybe a medicine rotation per se, where you're assigned a patient and you kind of follow them. You're there to get as much experience as possible and decide whether or not you want to go into that field, but you're not necessarily in the nitty-gritty of patient care constantly. You sometimes around, so on and so forth, but you then go to a case and you're kind of alleviated from those responsibilities. You're not kind of multitasking within that. As a resident, as an intern, you find that those responsibilities stick with you throughout the day, overnight if you're on call, and then you have to transfer care to the resident next day. And I think that responsibility is a huge factor in transitioning from a sub-intern to an intern. The other thing that people, we all talk about, but we sometimes, I guess, negate the significance of is navigating through the hospital. There's no textbook that kind of tells you what floor nursing is amenable to doing what and how to get social work set up for patients and just how to order certain medications within different hospital systems and the protocols of when to discharge a patient. There are a lot of things that the intern has to juggle and learn fairly quickly, and the learning curve is steep. But I think, most interns, you say that they're kind of like the masters of navigating the hospital within a month. They're the main ones who know how to get a patient discharged to an IPR ASAP and know which social worker to reach out to, because the concentration of all of the hospital inner working that you're interacting with is so high in the first couple weeks that you're kind of forced to learn. But it can be hard.
Let me ask you another question about that. You're right. It is hard. You're expected to show up on day one and know how to do these tasks, which you've likely never done before. How do you learn? Are you talking to your other interns and learning from them? Is there somebody when you come on to the service? Are you learning? Are you getting sign out from the previous intern? Is there anything written that people are passing along to you? How did you navigate that personally?
I think I was very lucky. I had an amazing PGY2 on my first rotation as an intern. He walked me through everything. And when he wasn't there or available, the foundation that was laid allowed me to, I guess, ask the right questions to hospital staff. So just inquiring, it's kind of like customer service. You just keep asking and they keep forwarding you to the next person until someone has an answer for you. And then you learn the pathway, and then it's more efficient the next time you do it. But first couple of weeks, a lot of tedious work.
Yeah, I think that's a really good lesson, though. And I've heard a lot of the same from our interns, is that those kind of middle residents, not your chief residents who are running the show, but, the other residents who are kind of supporting the service, they're so critical to set up the intern for success. And they can make a huge impact for the intern's experience if they are helpful and give guidance and serve as a sounding board. And if the interns know that those second, third, fourth year residents are, open and available for questions, it makes a really big difference in the experience of those interns. And so we've talked before about, how do you gain leadership abilities in residency? And here's an opportunity for more junior residents even to step into that leadership role and make a really big difference.
Yeah. And I think for any senior residents or upcoming senior residents, this is an important note. Think back about your experience and those residents that helped you. You're going to love that person forever. You're going to think of them forever for helping you during that time of need, and that's an important mentorship role to fulfill, I think. And part of the bonds of residency that make them so tight and make those experiences so memorable. I think before we leave this subject of allies, relationship with nurses is something that sometimes interns can struggle with. What may seem as constructive criticism from a nurse may not be interpreted that way. How did you build a strong relationship with the nursing staff, kind of like an allyship? How would you suggest interns build trust with the nurses?
I think definitely entering a relationship with humility. I think understanding that fundamentally, on day 1, probably on day 30, they still know multitudes more than what we know in terms of navigating the hospital, and they're a resource. They were one of the main people that I would ask questions about how to get things ordered, how things normally run, how fast does a bolus normally go so I can accurately place an order. Nursing knows all of the answers to these questions. And, when you use them as a resource, and also, we're now like around the same age group. A lot of the time you see them as friends. You guys can have a very symbiotic relationship in which they help go the extra mile. They update you frequently about things that are of particular importance to you regarding your patients. And you're able to learn a lot.
Yeah, I think that's so true. And it's funny, Gina, I was going to ask about exactly the same thing because it's such a critical part of being a junior resident. And, just thinking about the structure, on a floor, there's nurses, that cover multiple patients. And then there's a charge nurse who really runs the floor. And I think that charge nurse can also be a really important person to have as an ally. And that person, if they develop a good relationship with you, can really do a lot for you in terms of managing the floor. And that's a person where when I was an intern, I would always look every day, who's the charge nurse today? Introduce myself if I didn't know them. Tell them that I'm open to learning and to feedback and to call me if there's anything that comes up. And before I left the floor for the day, I would go, check in with them as, hey, I'm heading down to clinic or I'm heading to the operating room. Is there anything that I can help with before I go? Or here's when I'll be back, and here's how to get in touch with me. And those can be really helpful relationships to build.
Yeah, I think that's such a great piece of advice there, Lindsay, that if you're reliable and you develop a good relationship with the nursing staff, you can mutually be respectful of each other's time. They may hold that page until they know you're going to come back because they know that you're reliable and you're going to follow through. And then also, as a daughter of a nurse, my mother, I've always had her perspective. And, one of the things she always told me was that I spend most of the day with the patient. The nurses have on the floor between 3 to 5 patients, but most of their day in and day out with that, they're honing in on those patients. They know those patients very well. So if they have a concern, always take it seriously because they're kind of the lifeline with the patient and they are really have literally a pulse on what's going on. So don't ever, always validate their concerns. And I think that that lays very good groundwork for a good working relationship throughout your residency. All right, so we might want to switch gears a little bit to talk a little bit about, how do you triage? So this is tied to the nurse room. You have, I guess when Lindsay and I were residents, we had devices called pagers that were strapped onto our pants. But nowadays, you guys all have smartphones.
Oh, no, I still have a pager. It's right here next to me. It's hanging on its last lifeline. I got one.
All right. So you're getting bombarded. There's so many different ways that people can get in contact with you that we probably didn't have as interns and residents? How do you manage that? How do you triage, prioritize, and kind of move forward with all that information coming in?
I think it was really hard as an intern. I think a lot of us try to do things in chronological order. So if we're in clinic, we want to see this patient first before we answer that page because the patient had been waiting and yada, yada, yada. I think as I've gone through residency, I think one of the important tenets to me has been just gathering all information first. I know what the patient in clinic is here for. I don't know what this page is about. Let me quickly call, get some baseline information, and then we can make a decision from there. A lot of the time, they're quick pages, and then you actually end up knocking it out, as opposed to building up a long list of pages, creating anxiety for yourself in that aspect. But I think with regards to once you've gathered the information, triaging that information and seeing what's most important, I think that comes from experiences, obviously, but also just querying those around you who are more senior, whether they're your chiefs or whether you're staffing something within attending, getting a feel as to how they navigate through the situation, their sense of urgency. And if you have time, asking them about other variations of that situation so you can get a greater understanding of how to manage different manifestations of a particular clinical presentation. And then adding that to your whole dictionary, I guess, or book of situations that you're familiar with so that you can kind of prioritize what's important, because time is the most limiting factor with us. We're always multitasking and we always have to choose what is most important at this point in time. And so just quick processing of information, which obviously comes with repetition and seeing things a lot, but being intentional about gathering experiences and information from people more senior than you definitely helps our comfort levels in pushing something to the side or urgently dropping something and going to see a patient.
Yeah, I think that's really insightful. I like your idea of the dictionary and kind of, creating this dictionary as you go. Two things I want to pull out on that and ask you about. One is you mentioned multitasking, and we've already talked about that a couple times this morning. And what are some practical tips for, multitasking and making sure that you're following through on all the things you need to do?
I think, having whatever working list, if you have a notes in your phone, which I think is most helpful, because when I write things down, I always leave the paper at the last place that I was. My phone, I usually keep with me at most times. Communication. I know a lot of us are doing consults in clinic, running around, and keeping people updated, whether it's the difficult Foley on the floor that you can't do until you finish your cysto, or it's your clinic nurse who's had the cysto in syrups for 20 minutes now, and you got to let them know that, hey, it's going to be a little bit. But once you determine what you're going to do, remembering that, it's a system around you, and we got to keep people updated, and that actually helps optimize and keep the system moving.
Yeah, and I think the other thing actually that speaks to a little bit, the other thing I was going to ask about is, there are some rotations where interns are just holding the pager and running the floor. And in some ways, that's a little bit easier because you're managing the inpatient service and you have this defined task and you can triage things a little better and prioritize things better. But there's other rotations where you're holding the pager and you're in clinic, you're in the operating room. And, if you're working with an attending and they're hearing that pager go off all the time and, you're trying to both be present in clinic and learn from them and show you're interested while also managing this kind of constant pager. Speak a little bit to how you manage that relationship of making sure that you're kind of doing time-sensitive things that the pager is calling you to do, but also trying to be engaged and present in what your other assignment is.
Yeah, particularly in the OR where I don't have the opportunity to answer my pager myself, I usually, let if I can't, as like now at PGY2, PGY3, you're usually working with somebody else. Sometimes you can ask your co-resident who is not in the operating room, who's not scrubbed in to help with holding your pager temporarily. But if you can't do that, just talking with the circulator, or if they're not scrubbed in, if they could potentially call back pages and tell them what questions you'd want them to ask, just general triaging questions. Is this patient stable? Generally, if the provider doesn't think they're stable, this is something that you'd unscrub for, and you'd get on the phone and kind of see for yourself. A lot of times, we're like the central spot for scheduling issues, for discharge planning, for consults that have been seen in the past. So there's a lot of questions like that in which the nursing staff can help you with, just writing down the patient's information and what they needed, and you could just check up on it after the case. And it allows you to feel less stressed and actually more present, knowing that it's nothing to worry about, as opposed to just letting your pager keep beeping and do the repeat beeping and interrupt your tending as they're teaching you, and also interrupt your train of thought and ability to pay attention.
Yeah, those are great pearls of wisdom. For sure, I think engaging the people around you, your co-residents, the nurse, the circulator, and then getting some really objective information, like asking for the vital signs. This moves from someone's interpretation of what's happening to concrete data. So that's something that you can always use. What was their urine output? What's their heart rate? What's their blood pressure? That type of thing. And then also, one piece of advice our chiefs have given our juniors is that you're getting a lot of pages, maybe descriptive of what's going on. But if you just ask, how can I help you? How can we help you? It kind of forces that service to really hone in on what exactly they need from you and what their concern is based on their knowledge of that patient. So you can help us because this patient has gross hematuria and, they're fully... So it really has them hone in on what the issue is, which might be vague depending on how they're contacting you or describing the problem.
Exactly. I think it goes back to talking about, relationship with nursing, and it's so critical. And I see our residents do an awesome job of it. They go into the operating room, they introduce themselves to the circulator, they say, hey, I have this pager. I know it's super annoying to have to deal with this, but it would help me so much if you could call back when I get a page. And I think, oftentimes the question of, how can I help? Or saying, I'm in the operating room right now. Is this something I can deal with when I get out? Is often helpful because it puts it in context, and people don't know when they're paging you. They have no idea what your role is, what you're doing. Are you just managing the pager all day and you can answer it and respond to anything? Or are you also in the operating room doing a case? So giving somebody a sense of saying, hey, I'll be out of the operating room in about 2 hours. Is this something that can wait until I'm out? Or do you need me to talk about it now? And if it's now, then you scrub out and you deal with it. And that triaging that happens, and like you mentioned, sometimes it's happening with the circulator having to do the work or hold the phone up to your ear. It's challenging. And so the other part of that is making sure your attending knows, hey, I'm holding the consult pager today. I'm going to try to make sure that I stay engaged and present in this case, but I might have to, triage a few things as they come in. Or, hey, just triage this consult. It sounds like it's something urgent that I need to deal with. Can you let me know if there's a good time when I can step out and deal with that? So just having really open communication, I think, can help build relationships rather than distract from them.
So true. I think we're going to keep moving forward. And really now we've been alluding to surgical skills and as an intern, really the focus of this year is to learn about the floor care, the inpatient care, the triaging, the consult patient, the basic of, management of certain urologic conditions. But there's also the surgical skills component. What are reasonable goals as an intern for surgical skills and involvement in procedural care? And how did you kind of build upon these skills?
Yeah, I think just breaking this question down by, I guess, case and procedure type, I guess open surgeries, endoscopic surgeries, and then maybe clinic-based procedures. For open surgeries, I think it's really nice that a lot of the practice can happen outside of the operating room. We can practice knot tying, we can practice our suturing, and we can also, because we're depending on what kind of the rotation distribution at a program, you're going to peds pretty early on, and you can practice, using Castros and suturing with suture that you can't see and using your loops and everything outside of the operating room, so you just feel a little more comfortable before you get in and you're operating on little babies. In terms of endoscopic skills, I felt like that was a little harder for me. One thing that I did is when I did have time, I would just get into each of my cases maybe like 15, 20 minutes early, and I would put together all of the scopes. That way, I mean, like, I get to see the way all of the knobs turned, and if I'm fiddling with it, nobody's watching me and saying, go faster. I'm kind of just making sure that I know exactly how to screw in a Storz resectoscope, and I know how to match the zeros and the ones, and I'm actually looking at the instrument and I'm not stressed, and I get a good understanding of all of the tools, and doing that repetitively. And a lot of times, you also will have like a fellow in your cases, and so sometimes if they're in the room early as well, utilizing them and asking them, how certain tools are put together, or, I always have difficulty with this portion. The scope always, I always have difficulty putting this particular portion together. Why is that? And they can help you optimize in a low stress time. And then with regards to procedures, I think for me, that was like the most guided education that I got, because, you get to do them in clinic. You're typically not alone. You're not really rushing much, and you're with an attending or a senior usually, especially in the beginning. And so they're showing you how to maneuver the cystoscope. They're showing you how to insert the truss probe and how to optimize, why positioning is important, and how to better visualize the prostate. And so they're with you in real time, usually until you feel like you're 100% comfortable and you're able to do that by yourself. But you get a lot of reps in, which I think is really nice and important. So
I want to pull out a little bit of what you said about procedures. And I teach the interns a lot of procedures at our VA hospital. And one thing I've found, and that they've said in talking with them, is it's really helpful in the beginning for them to watch somebody do a procedure. And, that person's explaining to them exactly what they're doing. Then it's really important for the intern to just do it themselves. Like, give it a try. And you're going to fumble, and it's going to feel awkward. And you're going to realize that as much as you thought you knew how to do it, you really don't. But you're going to do it a few times. You're going to build up some understanding of what's good, what's bad. How do you need to turn your hand? How do you flex? And then you're going to ask your attending again, hey, now that I've done this a few times, can you show me again? And when you look that next time, after you've had a little bit of experience, you're going to pick up on a lot that you didn't pick up on the first time. You're going to look at how they're holding their body, how they're changing their wrist angle, when they're, bending their thumb on the scope. And you're going to pick up a lot of these kind of really nice kind of tidbits that in the beginning you were just focused on, like, how does this thing work? So I think it's really useful to kind of come back to that and never feel embarrassed to say, go to your attending and say, now that I've done this a bunch, I just love to see you do it again so I can watch you and pick up on some of these nuances that I might not have gotten before.
I think it's all in the reps, and it's all in the varying layers of attention to detail each time you go through the same time. I don't know, thinking back on my own experience during residency, which was a while back, what was more nerve-wracking for me wasn't necessarily learning in the operating room with an attending, but doing certain bedside procedures on my own for the first time as a consulting resident, like on the weekend or in the evenings and a conscious patient with, like INDing an abscess or putting in a complicated Foley or putting in a suprapubic tube. These are things that you're going to learn to do independently on a patient that's awake. And so what advice would you give in those scenarios, Oni, based on your experience and your learning curve? And then Lindsay and I can jump in based on our own experiences.
I think the biggest thing is that the first thing I thought of was the first time that I took down a priapism as a 2. And it's just, don't be afraid to phone a friend. I called my PGY3 and I stood outside the room and he talked me through everything again and made me go through all of the steps and what I was going to do. And he was like, okay, you got it, friend. And I went in and did it and called him and I was like, I did it. But I think like never being afraid to call your senior resident who's on backup call with you, or another junior resident who is ahead of you or has done the procedure before, just to run them by what you feel like you're going to do. Because at this point in time, you at least have some kind of baseline understanding, or I guess a couple experiences under your belt. You still don't feel comfortable, so you don't have all the reps in. Sometimes, they'll also give you strategies, to optimize the procedure as well. Like, hey, for this guy, I know you said this, maybe it might be better to do this first prior to doing that, because that might make it a little bit easier. And that's something maybe you wouldn't have thought of if you didn't reach out to them first.
Yeah. And I think too, like thinking through your procedure ahead of time, visualizing it is actually really important. And I think this goes for surgery too, but especially for procedures, because the worst is when you get in the room, you start your procedure and you realize you don't have everything you need, right? It's the worst. It happens to all of us.
On the other side of the room. Yeah. Yeah.
And so if you can visualize your procedure ahead of time, literally from the start of, prepping the patient or getting them on the monitor or whatever that kind of first step is, all the way through the end, you can have a checklist of, okay, what instruments do I need? What materials do I need? Who do I need in the room with me? And then you also know how to set expectations for the patient, because Gina, you're right. Like this is often, you're doing these procedures that you're still learning how to do on patients who are awake, and, establishing a rapport with that patient and letting them know what to expect. And even, during the procedure, really talking to them about what you're doing can be really helpful. And so I think, thinking of that whole process ahead of time takes a little of the stress out of it once you're in it, because you've pre-thought about it. You've tried to think about, contingency plans. You have everything in the room that you need. But you've also told the nurse, right, in the emergency room or wherever you are, hey, I'm going to be doing this procedure. There's a chance I may need some help. And if I kind of, stick my head out of the room, will you just be kind of looking out for me so that if I need something else, I can, ask you about it? Like these things are so helpful to make sure that you don't get into a situation where you're scrubbing out of your procedure 5 times to go grab the other things you need.
And that also kind of lose the trust of the patient also in that process. But Oni, you also, understand that there are hospital systems and frameworks also in place to protect you as you start, that you're not going to walk in and be expected to do all this independently. Most hospitals require a certain number of supervised procedures with the backup, with an attending, with the senior resident before you can do these on your own. So that will be part of your orientation. So everybody should know that and feel kind of reassured by that. But Oni, tell us about self-study as a junior resident. How did you fit that into your schedule?
I think self-study happens best when it's organic, meaning studying with your patients. Depending on what kind of rotation you're on, you'll see a variety of patients, different presentations, and it's important to just take those opportunities to read up a little bit, either the literature or Campbell's. Make yourself abreast of the information surrounding that patient's clinical presentation. Get acquainted with the guidelines. I know, like when I was an intern and I was doing cystoscopy clinic, make sure the hematuria guidelines, bladder cancer guidelines are just like the Bible to you. You should effectively have them memorized at that point in time. And so in every season of your education, at the very least, you know that you are getting education on what you're actively doing clinically. And then, when you have time, because there's such little time, we do have didactics. Studying for didactics is always something that you can you move into your schedule. But additional study, it can be hard. Give yourself some grace, because I know a lot of us coming from medical school, we are like, well, we're super comfortable with every topic because we have the time to study for that topic before we go into a clinical rotation. But in residency, you're not afforded that. So trying to make things work within the systems that are there. And just knowing that, as a junior, you spend most of your time in the hospital, but that kind of, you migrate from spending time at the hospital to spending less as you become more senior. You will have more time to do more dedicated studying.
I think one thing you said is really important, which is you learn through patience. And reading a guideline by itself can be so challenging to actually digest that information and have that knowledge stay in your head. But if you're reading a guideline because you saw a patient that had gross hematuria and now you're reading the hematuria guideline, it kind of helps it come to life. And I think it helps you remember it a lot better. And so I think that's such a good pearl of advice is if you are in a clinic and, take even 1 or 2 patients out of that clinic at the end of the day and go read up on the guidelines, go read the core curriculum on that topic, look at weeders, like whatever you're using to kind of help yourself, really learn that information based on a patient that you have in mind, because it's going to stick in your head so much better than if you're just sitting down in the evening, reading a guideline in isolation.
So true. Oni, so reflecting back on now that you're soon to be a PGY4 and a senior resident, what are some pearls of wisdom that you would want to share with the audience about surviving the junior years of residency?
I think most importantly, that time moves really quickly. It doesn't feel like things are moving quickly when you're in the heat of them and you just kind of are trying to get to tomorrow, but things move really quickly. And importantly, that means that the opportunities that you may have during those time periods, you may not have as many opportunities as a junior if we're not intentional. So it's important to actually take advantage of things. I know that we're tired, and sometimes we don't want to do that extra case and kind of just want to go home at the end of the day. But knowing that sometimes this is the only experience we may have to learn from a particular attending, because, we're not doing as many endoscopic cases as more senior residents, and getting those experiences and making sure that we're truly comfortable with the cases that we are exposed to as junior residents. Super important, because you'll blink and PGY3 will be over and you'll be starting PGY4 year in 3.5 weeks, which is my life. And you'll be, happy that you're there, but, also reflecting on how quickly everything went. And it's important to make all of that time worthwhile.
Those are great words of wisdom. It's a challenge, but embrace it, because it's the foundation for the rest of your career.
Yeah, and I think you only have 1 year to be an intern. You only have 1 year to be a PGY2, and it's like the days do feel really long, but the years feel short. And I just went to our chief's graduation, and when you're a graduating chief, all of a sudden you look back and think it felt so long, but man, once you look back, it feels short. And so taking advantage of every day, even though you're tired, even though it feels overwhelming, showing up, learning what you can learn, putting the time and energy in to make every day count is really important advice. Well, Oni, thank you so much for joining us. It was great to have this conversation with you. And, I think you have a lot of great perspective for junior residents as people transition into their intern year and into their PGY 2 and 3 years, things to think about, ways to ground themselves, and taking advantage of the resources around them, whether it's the people or the system. I think that we know people go into urology residency are amazing. They're, we think they're the cream of the crop, and the skills are there. You just have to know how to put them to use. So with that, really excited to have had you on our podcast, and look forward to talking about more things education with Gina, thinking about, how we can talk about topics that are relevant to our trainees, and keep the conversation going. So if you guys have ideas for topics, please reach out to us. We're excited to continue the series with lots more great interviews coming up.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.